For those of you who don't know me, I'm Dan Lamb. I'm a nephrologist and palliative care doc at Harborview Medical Center. And then I'm also the medical director for the kidney palliative care team at Northwest Kidney Centers. Today, I'll be talking about concurrent care. And I spoke about this about 4 years ago when we had just gotten the program off the ground. So I just want to give you guys an update on where things are right now. I don't have any disclosures. And today we'll talk about what is concurrent care for those of you who are not sure what concurrent care is. We'll talk about why it matters that our dialysis patients have been excluded from hospice, how we came to have the so-called system that we have today, and then what data exists on concurrent care for dialysis patients. And we'll think about some of the potential paths forward to scaling access. So what is concurrent care? So for some of you, who've heard about concurrent care, you probably come across the term palliative dialysis in the literature, and this often refers to concurrent care, which is the ability to have hospice and dialysis at the same time. And typically patients are forced to stop dialysis in order to enroll in hospice. And to illustrate this, talk about a recent patient of ours that we saw through the kidney palliative care team at Northwest Kidney Centers. He was 67 and had long-standing, poorly controlled hypertension, had a biopsy that showed TMA, and he also has heart disease as well, coronary disease, had a stent placed, AFib, he had HFrEF, which recovered, hyperlipidemia, and a history of a TIA. And he started dialysis in 2020. He was on PD and was doing relatively well for a couple of years, and then started having some physical decline and was referred to us for goals of care and coping with serious illness. And over several conversations, it was clear that he really prizes his independence and would not accept living in a SNF. At the times, his team was worried about, should he be living by himself, maybe go to an adult family home? And he was very clear about his desire for independence. We were a bit worried about his social support. He had suffered pretty significant financial loss and divorced about 20 years ago, was estranged from his family, and so didn't really have much of a community up here. But sort of found connection with his church community, and his pastor then sort of stepped in to become his cerebral power attorney for healthcare and was involved in numerous discussions. And kind of fast forward over a couple of years, in the last 6 to 12 months of his life, he had recurrent falls and recurrent admissions as a result of this. And his quality of life was very poor enough that he was considering stopping dialysis. But from a religious standpoint, this was very difficult for him to kind of move forward with, even though his pastor supported him in potentially stopping dialysis if this was right for him. And so he enrolled in concurrent care for 3 months, had the support of his church community and a COPS caregiver, and died peacefully at home. So why does it matter that dialysis patients have been excluded from hospice? And clearly for our patient CC, he would have had a very different course if he didn't have the ability to access concurrent care. Either would have accessed care in the hospital at the end of life, or have a very chaotic dialysis or discontinuation, which he himself was very conflicted about. I think to answer this question, it's important to understand the degree to which the disparity dialysis patients face with regard to hospice access. And so this is a graphic of the share of all Medicare decedents who access hospice for at least one day. And so it's about 50% of Medicare decedents. That hasn't really changed over the last few years. In the state of Washington, it's a bit lower, about 41%. And people stay on hospice for about 18 days. Their hospice length of stay really has not changed for well over a decade. But this story is very different for patients who are on dialysis. And so Susan Wong published this well over 10 years ago now around the intensity of care at end of life for dialysis patients. And on pretty much every metric, dialysis patients experience a much higher level of intensity of care at the end of life in the last 30 days. Hospitalization, ICU admission, having intensive procedures done, death in the hospital, but also hospice use, which is which at the time was 20% compared to patients with advanced cancer at 55% and advanced heart failure at 39%. And fast forward to 2020, cancer patients receive hospice at almost 70% rate, and patients with advanced serious illness that are non-cancer at about 45%. But for patients who are on dialysis, it hasn't really budged all that much. Maybe has moved to about 26% or so. So Muslim Wachterman looked at 770,000 patients over an almost 15-year period. And dialysis patients in 2014 accessed hospice at an almost 27% rate. I think notably, dialysis patients who did access hospice enrolled for less than 3 days. And it was 41% of the cohort. And I think this is really striking because, when you think about what that transition looks like for patients and families, it's barely enough time to get the hospital bed into the home, let alone learn about all the medications and symptoms that they may need to manage, how to get a hold of hospice, et cetera. And so in the oncology world, enrolling in hospice for less than 3 days is an indicator of poor quality end-of-life care and a quality metric there as well. And the median hospice length of stay for dialysis patients is only 5 days. So it's very difficult for patients and families to really have that time to be together. It is a very chaotic transition. And so this is a graphic just summarizing the data that I've talked about so far. And that is that dialysis patients utilize hospice at about half the rate of all Medicare beneficiaries, and the median hospice length of stay is less than a third that of all Medicare beneficiaries. And so the current state is that for most patients and families, they're forced to make this impossible choice around stopping dialysis, even if it's helping them to achieve an acceptable yet diminished quality of life, or if they're just in a state of decisional conflict. And so it's no surprise that for most patients and families, they elect to continue dialysis, but are at risk for having symptom crises and have no other recourse other than to pursue inpatient care or have a very chaotic transition at the end of life where the expected prognosis after stopping dialysis is really dependent upon your residual kidney function. So how did we come to have this so-called system that we have today? Well, in 1967, Dame Cicely Saunders founded the first modern hospice at St. Christopher's in London, and she addressed a significant gap in medicine at that time, and that was the care of patients who no longer had a curative option. And she emphasized not only physical symptom management, but also the emotional, spiritual, and existential symptoms that may occur for people. Most patients did not have a curative option, but notably St. Christopher's did offer concurrent care. They didn't call it that at the time, but some patients were on chemotherapy and received hospice services. And so fast forward to 1982, when the Medicare hospice benefit was passed, sponsored by then Representative Leanne Panetta and Senator Bob Dole. But in the middle of these negotiations, the budget director for the Reagan administration was really concerned about how much the Medicare hospice benefit would cost. And so there were some restrictions that were placed, and namely it was the restriction in eligibility to a prognosis of less than 6 months. What it provided was an interdisciplinary team, so included physician services, nursing, social work, some form of nutritional and spiritual counseling and home health aides, all with the ability to go into the home, and covers medications, DME, and medical supplies. And I'll talk a little bit more about the reimbursement and how that really is the main issue that has been a barrier in terms of being able to provide concurrent care. I will say in 2020, there were some changes to the hospice regulations such that effectively hospice agencies were responsible for the entire cost of a patient's care who enrolled in hospice. And so, there are, a number of different barriers to hospice access for dialysis patients, but really the one that worries me the most in terms of being able to scale access is the cost of in-center hemodialysis. And so hospice agencies are paid a daily rate. So it's about $150 to $200 per day. And out of that, they have to pay for the total cost of care for the patient. So all the labor of people in interdisciplinary team going into the home, providing 24/7 coverage for severe symptoms that require someone going into the home, medication, DME, et cetera. And if they were to offer sort of a palliative dialysis option, they would also have to pay for dialysis. And that becomes cost prohibitive, especially for hospice agencies that are much smaller. So a large hospice agency is about 500 patients on a daily census. And those are hospice agencies that may be able to afford the cost of hemodialysis. Unfortunately, it's only 1% of hospice agencies across the United States. So what data currently exists for concurrent care in dialysis patients? Well, Jane Schell and Doug Johnson and their group out at DCI, so Dialysis Clinic Inc. is a nonprofit kidney health provider, and they provide dialysis in the Pittsburgh region. And they worked with Family Hospice, which is a hospice agency also in the Pittsburgh region, to form a concurrent care program. And their eligibility criteria was a prognosis of less than 2 months. And if patient and family goals were aligned, they could receive up to 10 palliative dialysis treatments along with hospice. And they published this data back in 2022, and at the time they had enrolled 43 patients with an average age of around 74, although the range was pretty wide. Most patients were hemodialysis patients, about 10% were peritoneal dialysis patients. And as you would expect, patients had a fair degree of comorbidity and with comorbid conditions that you would expect. So for example, 72% of patients had congestive heart failure, about almost 30% had dementia. And when they looked at healthcare utilization outcomes, there were only two encounters for ED visits and 2 hospitalizations. And the median hospice length of stay was 9 days. So recall that for dialysis patients who are typical Medicare beneficiaries, the median hospice length of stay is 5 days. For those who received dialysis, it was 13. And most patients died at home, some in patient hospice and some in a skilled nursing facility, none in the hospital. Interestingly, a little less than half received 1 or more dialysis treatments. That means, more than half of patients elected for concurrent care, but ultimately decided not to have another dialysis treatment. For patients who did receive dialysis, the mean number of treatments was 3.5 for those in hemo, and then 19 treatments for those who were on peritoneal dialysis. I also did a qualitative study interviewing 9 caregivers and 13 clinicians. And I want to highlight one of the themes here, which was the program facilitates goal concordant care near the end of life. And, I think goal concordant care is something that we all aspire to, no matter where someone is in the health trajectory. And I just want to read off a couple of caregiver quotes here. One who said, "I just thought it was really the best of all worlds." And another who said, "My sons were here and they were able to enjoy their loved one's company. So it just meant that he had a good quality of life while he was on hospice." And so I think this is really the difference in terms of how we can help people write their stories, even at this very difficult time, that we're able to help them be patients, be family members, be friends, as opposed to chaotically trying to deliver the kind of healthcare that people need at this time. So the VA also has experience with concurrent care. The VA has been a pioneer in many different models of care, and concurrent care is no different. 5% of veterans were accessing hospice back in 2006. And so the VA came up with a comprehensive end-of-life care initiative in 2009, and that allowed for concurrent care, not just for patients on dialysis, but also for other conditions as well. And so Melissa Wachterman and her group looked at VA decedents who had USRDS data over an almost 10-year period, 2007 to 2016, and noted that 26% of veterans with end-stage kidney disease received hospice services. 28% of those patients who accessed hospice had concurrent care with a median hospice length of stay of 43 days. So again, recall that for most patients in the US who are on dialysis, if they access hospice at all, it would be about 5 days. And so concurrent care was really accessible to veterans because the VA financed dialysis. So this dark teal indicates that Medicare was a dialysis payer. And these other sort of lighter blue bars are different ways in which the VA financed dialysis. I think also interestingly, if Medicare was a hospice payer, patients had much lower rates of accessing concurrent care, so about 25%, as opposed to if VA was the hospice payer, close to 60%. So I'm going to switch gears a little bit to what we're doing here locally. So when the kidney palliative care team started back in 2017, we quickly encountered patients and families where they recognized their overall health trajectory. It was really important to be at home. And we, unfortunately, were not able to access concurrent care for many patients. It created sort of moral distress, not only for patients and families, but also for our team as well. Because we could see that there was infrastructure literally in our backyard, but we could not access it for our patients. And so this led to a number of conversations with hospice agencies who were very attuned to the fact that dialysis patients were underutilizing hospice and probably could benefit. And in 2019, we entered into Northwest Kidney Centers, entered into a formal contract with Providence Hospice of Seattle, and we enrolled our first patient in concurrent care through that program at the end of December of that year. And fast forward to 2023, Providence Hospice of Seattle has a sister hospice agency called Providence Hospice of Snohomish, and NKC now has a contract with them as well. And so if an NKC patient lives in the geographic catchment of these two hospice agencies, King, Pierce, and Snohomish counties, then they'll be able to access concurrent care. And so we look back at the decedent data for patients who are seen by our kidney palliative care team between 2017 and 2023. There are 278 decedents with an average age of around 72. Close to a 60-40 split in terms of male and female patients. And you can see the race and ethnicity breakdown here based on the 2728 form. Decedents who are seen by our team utilize hospice 47% of the time. And of the 47% of patients who utilize hospice, 42% utilize concurrent care. The median hospice length of stay for patients who elected to enroll in hospice was 8 days. And for those who utilized concurrent care, it was 22.5 days. The median number of palliative dialysis treatments was 4 treatments. And this is 4 hemodialysis treatments. We also took a look at hospice utilization pre and post the first Providence contract. And you can see there was an association with an increase in hospice utilization from 42 to 49%, and then in terms of concurrent care, 28 to 46%. And so this is a graphic sort of summarizing data with regard to hospice utilization through concurrent care locally, where patients were seen by our team, utilized hospice close to that of all Medicare beneficiaries at 47%, 20% of patients receive concurrent care. And for those who utilize concurrent care, the median hospice length of stay it's at least the same as, if not a little bit more than, that of all Medicare beneficiaries at 22 days. So what are the potential paths forward to scaling access? And this is where the conversation gets a bit trickier. It would require new legislation, potentially a regulatory path forward through CMS. So I'll start with the latter, and that is that there were recent clarifications to the Medicare hospice benefit, and they had requested some additional information around payment mechanisms for what they called high-intensity palliative care services. And CMS had identified that there were complex populations who had high palliative care needs who do not utilize the hospice benefit. And they had singled out people on dialysis, those receiving palliative chemo and radiation, and then blood transfusions for patients with advanced blood cancers. And they had heard from patients and families that they were told by hospice agencies that Medicare doesn't allow for these sorts of treatments. And so CMS said, hey, that's actually not true. We would cover palliative dialysis, palliative chemo, palliative radiation, and palliative blood transfusions. And so there's additional work to be done here. I think, unfortunately, we can't get additional clarification until there's a new CMS administrator. And so pivoting to sort of new legislation, so Representative Earl Blumenauer, who's now retired, and was a representative out of Oregon, introduced the Hospice Care Act in September 2024. It was a more comprehensive sort of revision of hospice in general, but it also provided for palliative chemotherapy, palliative radiation, palliative blood transfusions, and then palliative dialysis, initially with 10 sessions, then requiring a prior authorization. And in order to fund this, hospice agencies would have gotten 400% of their daily rate. And that would have covered palliative dialysis costs. So the good news was that it was introduced, but the bad news is that's as far as it got. And of course, September 2024 is a much different time than where we are right now. Concurrent care is obviously one area in which we can improve kidney care, but there are obviously many facets of kidney care and healthcare in general that we need to be advocating for. I think the argument potentially for either a legislative path forward or even a regulatory path forward is that there may be the nice side effect that total Medicare costs at the end of life for dialysis patients is less. You might have increased quality, but it does not seem, at least with the data that we have so far, that there is increased cost. And so this is cost data from our team for patients who accessed concurrent care between 2018 and 2020. So Northwest Kidney Centers was part of a CMMI demonstration project, and we had 61 decedents who had cost data. And so we broke them down to patients who did not receive hospice, patients who were on concurrent care, and patients who stopped dialysis and were not on concurrent care, and looked at total Medicare costs in the last 30 days of life and the last year of life. So there's no clear signal that hospice, concurrent or not, costs more than patients who do not receive hospice and potentially could cost less. And Melissa Wachterman and her group in the study where they looked at 770,000 dialysis patients also looked at healthcare utilization and costs by hospice length of stay. And in these two bars, these are patients who access hospice for more than a week, so 18 to 14 days, and more than 2 weeks. So patients who had higher hospice length of stay had lower mean costs in the last 7 days of life as compared to patients who did not receive hospice, had hospice for less than 3 days or 4 to 7 days. And the less than 3 days, I imagine that many of those patients, they had a terminal hospitalization or either admitted to general inpatient hospice, so it's essentially a hospice in the hospital, or discharged home. So in summary, concurrent care is the same as palliative dialysis, which is the same as hospice and dialysis at the same time. Dialysis patients experience higher rates of intensive end-of-life care as compared to other patients with advanced serious illness. And payment structures have led to systematic disparities in hospice access for our dialysis patients. But models of concurrent care are associated with increased hospice utilization and median hospice length of stay for our dialysis patients, so better quality end-of-life care. And there is data to suggest that longer hospice length of stay is associated with lower end-of-life costs for dialysis patients. And scaling concurrent care would need to take a regulatory or legislative path forward, but there are potential avenues forward. And so as I close, I'd like to share one of my all-time favorite cafes, and this is Cafe Bessely, which used to be in Ballard. The longtime owner and acclaimed pastry chef moved to Spain with his family. But the first time I had a croissant here, I thought to myself, oh, this is what a croissant is supposed to taste like. I couldn't believe how good it was. And, a few years later, my wife and I were visiting Paris, and we were talking to a bartender who's also a pastry chef who turned out to have trained in the Seattle area. And of course, the conversation turned to how good Bessely was and how it was better than most places in Paris. And so I'm sharing this story with you because, once I had a croissant from Bessely, I just couldn't go back to whatever I was eating before. And I also don't want to imagine going back to an environment where concurrent care is unavailable for our patients. And so I want to thank you for your attention. And there are too many people to thank for standing this up. But first and foremost, I want to thank patients and families who are the inspiration for doing this, for my teammates, Megan Nolan, Jensen Royer, and Leila Woolsey, for their tireless work. I think Matt and Suzanne are also on the call and have advocated for concurrent care as well. And I also want to highlight Jennifer Lichty, who did a lot of work in standing this program up, as well as all my colleagues at Providence Hospice of Seattle and Snohomish for making this work. So with that, thank you so much.
Thank you so much, Dan, for that overview and for really being a trailblazer, I'd say, in this area. Thank you for all that you do. We have quite a few questions and comments in the chat, as well as why don't we go ahead and start with Anne? Did you have your hand raised? And I can read off some of the things in the chat as well.
Oh, yeah, that was just so amazing, Dan. And I just think your work, as echoed in the chat, your work in this area is incredible. It's been a heavy lift, and it's sort of amazing, how much you've been able to accomplish by your just very thoughtful, committed approach. And your conclusion, that legislative changes are needed, and yet you've been able to accomplish a lot. So I guess I'm curious if someone came to you and wanted to do what you've been able to do, what would your key advice be? What was it, that made this? What were the most important things that made this journey that you've taken possible? That could be sort of helpful to others trying to do the same.
Yeah, I think it's critically important that there's a dialysis champion and that there's a hospice champion. In terms of just, this is the nuts and bolts of sort of making sort of a concurrent care program work. Because there's a lot of work that leads up to patients and families being ready for concurrent care. It might be goal aligned way before, say, you might be having this conversation, a year or two before patients are, needing to access this. But, people may be able to articulate their values in a way where it makes sense for them to plan for concurrent care, but the readiness may not necessarily be there. And it may not necessarily be the patient. The patient may be totally ready, but family members may not necessarily be ready. And so having the timeline to be able to have those conversations to make sure that everybody's on the same page is very helpful. And of course, people can make, decisions quickly. Oftentimes, if there is, a significant hospitalization that may, serve as a way to for people who are stuck in thinking about care in a certain way to then sort of rethink how to support their loved one, for example. I think having a hospice champion has been really important for us here at through our collaboration with Providence Hospice of Seattle. So Skylar Coppola, she's our current hospice liaison, and so she sees all the concurrent care referrals that come through. We talk every quarter. In fact, today we're going to have our quarterly meeting with Providence Hospice of Seattle just to see, hey, how are things going? We kind of debrief things that went well, things that could go better, and just make sure that everything, there's always something that you can be doing better. And I didn't show a slide around our process, but there's something that was surprising was that inpatient teams were referring for concurrent care, and so we had to put some guardrails around that. I think what we had heard was that as a way for our hospitals to discharge patients home quicker and to give patients an option of being able to go home, but it wasn't clear that every patient was actually eligible for concurrent care. And hospice agencies like, are they actually, do they really have a prognosis of less than 6 months? So those are things that we sort of set in place as well.
Thank you.
Thanks, Sarah. A few comments and questions in the chat as well. I'll start with Suzanne Watnick. Again, thanks for a terrific talk. And she mentions that as an aside, the Blue and Hour bill was introduced in the 118th Congress, but nothing's been introduced in the 119th yet, although people are actively considering how best to introduce a hospice bill, but notes that not with as much dialysis focus. And also notes that Dan was on the Hill 2 weeks ago advocating for our patients. So thank you. And then Gao Yuan has a comment. Patient with ESRD on dialysis has hospice condition like end-stage cancer. The patient wants to continue dialysis while choosing hospice, but the patient can have months of life instead of days to weeks of life without dialysis. Can we do that? And how would you discuss with the patient in that scenario and help them make such decisions?
Yeah, so if the patient has a prognosis of less than 6 months, so this is irregardless of the sort of terminal illness diagnosis, they would be eligible for concurrent care through the NKC program. Now, for a patient in a different state where concurrent care is not available, unfortunately, they would have to stop dialysis. And so, having those goals of care discussions around, is this the best option for patients, would be important. So typically it's patients who want to prioritize comfort over longevity at this point in their lives. Typically they want to be at home surrounded by family and to avoid the hospital. And I see Leah's question about the rules around emergency room use and even patients who want admission. And hospices essentially they would have to pay for emergency room use and hospitalizations. And so effectively, this is not sort of hospice aligned from a payment perspective. But also, I think, these are folks who are probably more longevity oriented over comfort. And so these are folks where I do not enroll in hospital. We'll certainly have a conversation, and sometimes people, they want to, take this path for a period of time, and then they may then want to switch over to concurrent care.
Thank you. And I had a question, Dan, as well. Have you found any differences in ease or ability to utilize concurrent care in patients who are on, say, hemodialysis versus peritoneal dialysis?
Do you mean that one is more difficult than the other?
Sure.
Not in terms of eligibility or enrollment. So, so the patient I presented was on peritoneal dialysis, but we certainly have had people who do hemodialysis as well. I guess the one challenge with hemodialysis is transportation. And we're just very, very lucky in the Seattle area to have reasonable transportation, especially in King County. So, patients in a nursing facility can still have transportation covered through sort of some of the services that we have through King County, such as Access. And as much as HopeLink is a challenge, at least we have HopeLink. And, there are other areas in the country where transportation isn't quite as robust.
Thank you. And maybe one more just kind of logistical question. I think you may have covered some of this, but so if we have a patient that we're interested in enrolling in concurrent care, say over at the Montlake campus, for example, what would be the best route to go about initiating that? Would it be are we able to put a consult in to the
Absolutely. Yeah. So if you're unsure, just consult our team at, they have to be an NKC patient, but you can just put in an order to have the palliative care. Actually, there's under the Northwest Kidney Center's orders, there's a kidney palliative care referral, so you can place an order there. If you're comfortable placing a hospice referral yourself, you could also do an epic to Providence Hospice of Seattle. And so you can give a one-liner there. The regulatory magic words are prognosis of less than 6 months, and you should list the hospice diagnosis. So for example, if it's calciphylaxis, you can say that, or whatever the hospice diagnosis might be. And that would be sufficient.
All right. Well, thank you so much, and additional praise in the chat as well from Matt Rivara. Thank you, Dan, for being a leader in this area locally, regionally, and nationally. We are all lucky to have you be in our midst, and you in the program you lead are known nationally and serves an inspiring model for others. And I echo those same sentiments. Really, really thankful again for having you, and also for this very informative talk, and as another option for our patients as they approach end of life care. So with that, we're over time. So if there are any additional questions or comments, maybe best to reach out directly to our speakers.